I wanted to present our hydrocephalus research. We've done this before, but I think it'd be nice to show you what we're doing that is, I think, affecting national trends. And this will be a two-part topic. So I will be giving the basics, how we started, what we've done. And then when Joyce gives her grand rounds, she's going to present the updated applications, what was the next step up. So this will be a setup for Joyce's talk. Here are the data. About 40% of shunts fail in the first year after insertion. About 50% fail by the second year. The majority fail within 5 or 10 years. When people looked at that in more detail, they found that almost 3/4 of these are proximal shunt obstructions, the ventricular catheter. Why? I'm going to start by giving you a little bit of an overview of what we do in the OR. I think I added this because it's a neurosurgical grand rounds. So we have 3 types of endoscopes. We have the shunt endoscope, which is a 1 millimeter endoscope, goes in the catheter. We have the rigid scope that has really high quality. And then we have a non-disposable 1 millimeter scope. They really were made by the same company. And the advantages, as all the residents here know, is that the flexible ones, the small shunt ones, they fit inside the catheter. You don't need to mess with the track. You can go back into the same track without further injury to the brain, whereas the rigid ones, they're bigger scopes, and they need more room. You can't go around the corners easily, but you can do a lot more things with it. You can fenestrate cysts, you can fenestrate the septum, you can take out a blood clot, etc. So what is the advantage of shunt endoscopy? Safe catheter removal. I think it's number one. We've all been in situations where you take out the catheter and you cause a hemorrhage because it's attached to choroid plexus or blood vessels in the ventricles. So you avoid bleeding, you address adhesions, but also you want to optimize catheter placement. If you place the catheter in a corner or around choroid plexus, it may not survive as much. And then you want to optimize catheter survival. So if you can prevent loculations, it can prevent ventricular collapse. That presumably will decrease the chance that you're going to go back in at some point in the future. Here are various pictures that we've seen intraoperatively. Right there, you can see vessels running into the catheter, not just choroid plexus. There, it's a tight track. Here, we're fenestrating a septum. Here, we're going through the same track of an existing catheter, of a catheter we just removed. So avoid bleeding. This is intracatheter endoscopy. You go through a previous catheter, you pull out at the end, and then you can see where you are. So you're less likely to damage the tissues around it as you're doing it. Oh. A little bit slow. There you go. So this is going outside of the catheter. Oh, well, it's not going to play. So this is going outside the catheter. You can see those tissues growing in, including blood vessels. So the only way to get this catheter out safely is to go in with a cautery and cauterize these and pull them off. You can't just be pulling on that catheter. This is a sleeve around the catheter that has formed over years of shunting. In order to really be able to pull that catheter out of the sleeve and to be able to get in, you have to cut the sleeve as you go into the ventricle. So these are various manipulations, techniques that you can use to make the surgery safer. Here, we pulled out the catheter, and we're going to go through the same track so that you don't injure the brain again. And you can't do it with a big rigid endoscope, obviously, because you will destroy the track going in. Here, you're navigating through small ventricles. So it's very easy to navigate through small ventricles with endoscopes. Whereas if you blindly try to put the catheter in, sometimes you're going to cause a new track to form. But in this case, you go in and you optimize the position of the catheter. You have loculations. While you're putting the catheter, you can fenestrate the different membranes that are in there. Obviously, this is done more with the rigid scope, but it can be done also with a flexible scope with a sheath inside, or a Bugbee wire. There's the other side. Okay, so as we've done all these, I have probably about 2,000 endoscopic shunt surgeries. You can imagine, you can see a lot of stuff when you do that many procedures. So what we noted over and over and over again is that when you pull a catheter out, you will see bumps along the wall, lined up like a set of trees, very organized, that correspond to the holes in the catheter. And so we start seeing them over and over and over again. Now, when I talk to my friends who are doing it, they say, gosh, they're in the majority of patients, which we knew that. What are these? You can have different types, but the reason they're different types is this one, for example, we saw after pulling the catheter. So we sheared them as we were pulling the catheter. They were attached to the catheter. So they're all the same. It's just that it's what you do with them that makes them look the way they are. So the question is, what are they? Are they, outgrowth, inflammatory cells that are growing around the silicone tube? Is it suction? Is it... So we started taking video clips of these. And what you're seeing here is a shunt catheter that was disconnected during shunt revision. And every time that I plug the catheter with my fingers, the ventricle dilates, and that ependymal band pulls out. And every time you let it drain, it pulls right back in. And it can go back and forth and back and forth. So there's another example of it. Plug, it opens. Let drain, it closes. So it was obvious from all these videos that this was a suction mechanism. Drainage is what's causing these. So early on, they're reversible. As you can see, you increase the pressure, they separate. You drain, they pull back in. However, if you give it a few months, they start to get stuck. They sclerose. It starts out with ependyma going in, then you have inflammatory cells, and you have sclerotic tissue. And then they get stuck. And some of them get stuck permanently, some of them, you can take them off, and some of them just embed in the catheter. Then if you wait many months or years, they get so severe that they pull into the catheter and they break off inside the catheter. So that then the shunt obstructs. There's your 2 a.m. shunt revision. And it doesn't matter if the ventricles are small or open. It all depends on the compliance of the ventricles. If the ventricle opens, the catheter is still obstructed. Okay, so just to rehash it, In early stage, you have a reversible phenomenon where with drainage, tissues pull in, and with obstruction, tissues pull out. It's intermittent. And this, what we think, causes slit ventricle syndrome. Those children or patients that come in every week or every month, they have a bad headache, they vomit, and then they feel great. This is when they vomit, and then the pressure goes up, ventricles separate, they feel great. Now, if you look at these, sometimes the ventricles are large. They're not small, they're not all small. But what you find is that the part of the ventricle where the tip is going, where all the holes are, is always small. It's always slit, it's always collapsed around the catheter. This is intermediate, they start to stick. Some of the holes are still open here, the child is doing well, okay? Until you get to the severe stage. And now the catheter is obstructed. And in this case, the catheter obstructed, the ventricle dilated, the tissue pulled out, but there's still tissue inside the catheter. So what we've looked at that at the end, thanks to Mark's work here, is that shunts overdrain. Overdrainage causes the ventricles to collapse. Whether or not, when the shunt malfunctions, the ventricles dilate, at baseline, when the shunt is working, they're collapsed. They cause these ependymal bands that obstruct the catheter, either intermittently or permanently. And this is what you see. So shunt technology has been unable to improve on the rate of shunt malfunction in the past 6 decades. The 40% obstruction rate at 1 year that we have now is the same that we had in 1958 after Holter presented his first valve. So successful valve designs relies on understanding the pathophysiology. And for many years, we've not understood the pathophysiology of these. We didn't know why shunts malfunction. Okay, so many research labs were studying inflammation. Well, is there inflammation that's getting into the catheter and causing it to obstruct? No, it's just a mechanical problem. And if overdrainage causes shunt obstruction, then decreasing overdrainage should improve it. So when Mark handed the powers to Joyce, we looked at this study where we've been adding anti-siphon devices into these patients. This is a primary valve, and this is an M-blue valve. And initially, in the shunts who had the occipital shunts, the secondary valve would be here because it has to be farther away from the primary valve. Whereas when I started putting them coronally, then the secondary valve would be here, which is way more practical long-term for these kids. So we looked at 78 patients in 12 years, and this is what we saw. So this is the simple patient group. Simple patient meaning they have rare shunt revisions, less than 10 in their lifetime. And so with those, we decreased the shunt obstruction rate by 67% in the first year, by 43% by year 5. However, when you take the patients that many of my adult colleagues know here, who come repetitively, used to come repetitively to have shunt revisions, this is what we saw. At 1 year, we decreased the shunt obstruction rate by 76%, at 5 years by 66%. To put it in context, there's not been an intervention in the past 60 years that have decreased shunt obstruction rate by even 5%. Okay? Now, we're not the first to show this. In 2010, a surgeon in Germany published a paper in Journal of Neurosurgery that showed that when he added anti-siphon devices into his shunt system, he decreased his shunt obstruction rates by 90%, even better than ours. But nobody gave him a second look. This was published in 2010. Now we're showing why. Okay. This is Richard. I think probably Resnick and Dempsey have gray hair partly because of Richard. He had 150 shunt operations by the time he was 12. His last shunt operation was in 2008 on my birthday. And that was when I added an anti-siphon device in each of his 2 shunt systems. That was it. Oh, and the residents, Brooks and... yeah. I mean, he shows up for endocrine problems and things like this, and we visit. But, and maybe he'll need a shunt revision. I mean, it's not a permanent, it's not a, you know, a panacea here. But it's taken him from, you know, a really bad problem to a much simpler problem. Okay, so we talked about siphoning from gravity. This obviously causes shunt, it causes overdrainage. However, when we, Dave Shu is a physicist and a neurologist here who, I asked him to simulate shunts. And what is it that is really happening? And what he found, and this is something that has been actually shown before by a group that did ICP monitoring in one patient over 24 hours. They said what is happening is that each time there's an activity, such as a bowel movement, coughing, running, climbing upstairs, you have spikes of ICP in the brain. And the question is, what is this ICP doing to the shunt? Well, every time there's a spike, the fluid enters the shunt system. Now, if the coughing spike is 60 millimeters of mercury and your shunt valve is 15, you can imagine that those valves are always open because we're constantly doing something. You know, unless you're asleep, supine in bed without sleep apnea, you're not going to have a normal shunt drainage, which means all of these valves that we're putting in are pretty much always open. That's the second problem with overdrainage. And I would liken it to this picture that I showed before of Half Moon Bay. So Half Moon Bay in San Francisco has a breaker. So the breaker prevents waves from getting into the shoreline here. So you can see here, each wave is breaking on the shoreline and destroying part of the shoreline. But here, the waves break on the breaker, and then the fluid streamlines into the system here, so that you have no further damage here. And this is how we see overdrainage. These are the existing shunts. This is what we need, okay? And when we simulated it, we said, well, the existing valves, we call them the dumb valves, respond to instantaneous ICP. Every time you cough, it goes down. So if your shunt setting is at 10, your average ICP is going to be in the negative range. And the same with the amount of volume that you pull out. However, if you use a valve that is closed at baseline, only opens when you ask it to open, this is what you theoretically will achieve. So imagine when you cough, the valve is closed, but then when you average the ICP over 5 minutes, let's say, and it's above 15, it opens for a few seconds and then closes again. So that's really what we need. So Mark set up a survey of the American Society of Pediatric Neurosurgeons a few years ago. And the conclusion was that less than 5% of senior pediatric neurosurgeons think that overdrainage is even a problem with their patients. The majority felt overdrainage is not a problem. It's less than 5% of our patients. So there is really no understanding in my specialty how these things happen and why they happen. So we wanted to take it from the clinic to the lab, and Chris Lucio, who's an incredible engineer, mechanical engineer, and neurologist, set up this system, and this is version 2. We have, of course, improved it significantly over the years, but the idea, and it's sitting at Wimmer, the idea is that it brings in the parameters of compliance, pulsation, and gravity. So you can test this. There's nothing like it in the world. And you measure ICPs or pressures in the ventricle. This is called the pseudoventricle, before the valve and after the valve. The pseudoventricle gets fluid from this area. There's a pressure generator that gives you the pulsations. There's a compliance chamber, and there is height. So we've been able to do quite a bit with this. We have one published paper, and we have 4 ongoing now that Joyce will tell you about next time. But I'll show you the preliminary work, or not the published work. So first, gravity drives drainage. We now are showing this in the lab, that if you give height, and this is logical for everyone understands this, that the more gravity you give it, the more drainage you're going to have. And this is independent of compliance and pulsations. And the valve will decrease that amount, but will not eliminate it. Number 2, pulsations in the supine position increases drainage, whether or not you give a valve. If you have a valve, it's better, but it doesn't eliminate it. And then if you're supine, the effect is worse than if you're upright, because in upright position, gravity dominates. It's the bottom line. Low compliance leads to higher pulse pressures, so that the lower the compliance of the brain, the more the pulsations are going to drive over drainage. And the way I would view it is, if you take a baby and you shunt them, they have really good compliance. The effect of pulsations are going to be almost minimal. However, the baby loses ventricular size, loses brain cytoarchitecture, becomes non-compliant after 10 years of shunting, over-shunting, and all of a sudden, the pulse pressures have a much higher effect on that 10-year-old than it did on the infant. So these are the anti-siphon device results. So when we added an anti-siphon device into the shunt system on the benchtop, we've significantly decreased the volume of fluid that drained. But then we followed up with this, and I know you'll have questions about this, and this is a really important point, is that the biggest drop is between a valve that's attached to the primary valve and 5 centimeters away. You have a significant drop in drainage, but then the farther away you are, the better it is. And we can talk about this in a minute. So choosing an appropriate endoscope is key to minimizing complications during this kind of really morbid surgery. The goals of endoscopy is safety and optimal shunt function, and it allows neuronavigation, burr-hole location, catheter insertion. All of these play a role in increasing safety and optimizing care. We find that gravity and CSF pulsations cause overdrainage in shunt systems, evident clinically and on the bench, that this can happen in the horizontal position or in the vertical position. It can be due to just general physiologic issues such as Valsalva maneuvers and physiological pulses, and which tells us that the only way we're going to improve on the current shunt systems, you can imagine how many iterations of programmable valves and sophisticated valves have been introduced in the past 6 decades, but nothing has improved the shunt obstruction rate. And that's because they all are based on gravitational forces. So from this, the WHP team put together a set of engineers and scientists and physicists, and we designed a smart valve system that has an ICP sensor, electronics, and a valve that is closed all the time, except when you ask it to open. and it works based on a moving average. So over, let's say, 3 or 4 minutes, it averages the ICP, gets rid of those instantaneous pulses, and then if it's above a certain level, it opens for however long you want it to open, and then it closes. And this spun out into this startup, Madison Scientific, where we have prettier versions now of what we had been envisioning, with a near prototype available now, which would have the implant, the valve, external device, because that's important to monitor ambient pressure so that you can constantly be in sync. So if you go to Colorado, you're not going to have a problem. A charger that can be within a foot of the shunt and will charge for many hours. And so far we've been able to get funding. It's been going really strong. We don't have a functional prototype yet, but we have a prototype that's functional on the bench. And this is the team that is working on this. But most importantly, this whole came to be because of this team, the Wisconsin Hydrocephalus Project, where Josh and I were the main clinicians. Dave Shu is our physicist. Chris Lucio is our mechanical engineer. The late John Webster was our electrical and biomedical engineer. And the fellows, of course, Joyce, Mark, Anas and Roy, and some of the graduate students in engineering that we've had. And that's it. Thank you.
Benny, thank you very much. I've been for decades talking about the importance of pulsation from a cerebrovascular standpoint, in that you build this whole closed box system of the brain with hyperdynamic vessels sitting in the CSF to charge it, to pump the blood out on the venous return, which suggested to me that the classic shunts were robbing the brain of the normal venous return, pulsation, and probably IQ points over time. I'm really excited to see the fact that the smart valve allows pulsation, as opposed to thinking that that's universally bad. How do you arrive at 3 minutes, 5 minutes, et cetera? How long do you, to average it?
So we have a pretty cool software that will adapt to patient needs. So you accumulate data over months, and some of the advantages of this beyond what I talked about are obvious. You can get ICP waveforms on these patients anytime you want. You can send them to the iPhone, in the doctor's office. You can gather data over years. So there are major advantages to having this that we don't have currently, even with an ICP monitor. So you're absolutely right, Bob, about the pulsation issue. I mean, we're looking at a very narrow view of pulsations. What is the pulse introducing into the shunt? But there is a physiological advantage to pulsations that we don't understand. And Ben Wolf talks about this all the time. And we just don't understand. So when you take away this shortcut from brain to gut, if you want, you eliminate it and let the brain do what it needs to do, and only drain when you absolutely need to drain it. You don't want to empty the reservoir. You want to just take off the excess fluid. That's what you do. The other thing I would add to this is it goes beyond even shunt malfunction. We talk about shunt malfunctions because we're narrow-minded neurosurgeons. That's what we understand. However, if you talk to Mark about the project that he's doing with the Sandon Award, what we believe is that this over-drainage over years and years and years removes the compliance to the brain, eliminates compliance in the brain. Well, what is brain compliance? Brain compliance gives you a reserve, so that when you run up the stairs, your head isn't bumping around and causing headaches. But what happens is you see my patients who come in 15 years later to the clinic, and the parents will tell you, I can hang my child outside. He will tell me what the weather is going to be tomorrow. Why is that? because they have no compliance. They're sensitive to every little change in barometric pressure, in the climate, and that's all because of loss of compliance over years. Well, why would anyone lose compliance over years? Because you're over-shunting. So Mark's study compares ETV patients in infancy to shunt patients in infancy who grew up to 10, 15, 20 years old, and see how they're doing with headaches, how they're doing with their day-to-day activities, hopefully over time with their cognitive function. Is there a cognitive price to pay for losing compliance in the brain over years? So this is the bigger picture. The shunt really is the smaller picture, but the one which we can understand.
And all this evidence was staring us in the face all the time. Every time you do decompressive crani and you open this closed box, you destroy the normal pulsation and normal venous drainage and have these syndromes of the Trefine, et cetera. Every time you look at an aneurysm, you say, why is this vessel so thin? I have only one layer of elastic and so hyperdynamic. And why in the world is it sitting in CSF? All the other organs, the vessels are sitting in the organ. Here it's sitting in the CSF, which pumps and if you look at the pulsation waves, the arterial, then the CSF, then the venous pulsation wave, you can see that it's a mechanical pump pumping blood out. And you need that for normal compliance, normal function, normal intellect, I believe. So that's why the smart valve has been something that I've been thrilled to see you work toward for all these years, because the dumb valves basically take away a normal physiology.
Mm-hmm.
Thanks for the great talk. Later on down the road, I'm sure right now, but is this will this be MRI compatible? I'm just thinking like how.
Yeah, I mean, you can't design a valve nowadays that would not be MRI compatible. It will cause an artifact, but it'd be like the programmable valves. It's encased in titanium. Yeah.
So I'm wondering, upstream from the valve, right? You have the catheter that drain CSF. I'm wondering, has that been designed, for example, like adding some sort of grate over the holes or making the hole smaller, just so that you add more?
I'm sorry, I missed that.
I'm saying, like, has that been designed to that drainage catheter to basically increase resistance or increase blockage so that your brain tissue is not being suctioned into the catheter?
I don't understand the question.
He's asking like the proximal catheter, what have been the iterations of the design of
Okay.
tube with holes?
Yeah, I thought that. So look, for many years, and even to this day, a lot of the research going on in shunt function is about design of the catheter. Some people try to design catheters with smaller holes. Some people try to do. So now there is this reflow system where you push in, so you pump a little valve and it pushes fluid into the catheter, and theoretically it will unobstruct it, right? The problem is what you're doing here is you are backpedaling. You are trying to treat a disease that's already taken its toll on the patient. And it's really, it's not what we want to do. We want to prevent this from happening to begin with. And all of these designs have not really been proven to work, certainly. And, we've seen it. I mean, how often can you tap a shunt and inject fluid and unplug a catheter? It's very difficult to do this, especially seeing some of the pictures I showed you. These can be complicated issues with the catheter. It's not just a couple little pieces of brain that can be, yeah.
Ramoni designed a catheter with little wings to hold the ventricular walls away from the holes. It became so incredibly enmeshed in the brain that it was kind of like trying to pull a cork out of a bottle when you try to remove it, and usually remove the brain with the catheter.
Yep.
So there's a lot of interest right now in how slow vasomotion during sleep drives CSF in the perivascular space to create an anti-gradient for clearance of metabolic waste, sticky proteins, et cetera. There's work here to be able to visualize movement from the perivascular space from the parenchyma. It really strikes me it would be interesting during sleep to look at the effect of a smart system versus not in terms of CSF movement within the parenchyma to create an advective gradient as well. That there's a lot of links between the lymphatic clearance system and the meningeal lymphatic clearance system and hydrocephalus and the long-term sequelae. I'm just curious if you thought about looking at that.
It would be amazing. I mean, I thought it would be nice to see the fluid waves around the tip of the catheter, for example, right? What's it called? Finite modeling, right? Around the catheter. There are lots of things we can do to prove that we're changing the fluid physiology. So what kind of techniques do they use to do that?
TWI, so they're essentially resonating water molecules.
So they have them sleep in the MRI suite then?
Yeah.
I see.
So that's the.
Yeah, it'd be amazing to do stuff like that.
There's also.
Can they look around the catheter too?
It depends on how much artifact you get around the catheter itself, but there's also people just using FNIRS to look at CSF movement in places like prefrontal cortex and using a different variety that doesn't pick up the faster motion of the blood, slower motion of CSF in the perivascular space as well.
I mean, the other thing, I fully agree. The other thing I would love to look at with MRI is what happens to the brain cytoarchitecturally over years of shunting, as opposed to after treatment with an ETP, for example. What happens to the chemical composition? I mean, you have tau proteins that are accumulating over years, things like this. So there's a lot to do to prove that clinically.
Well, there's people doing blood draws hourly over the circadian cycle to look at the egress of essentially tau and whatever into the blood as well. So there's some interesting studies that can be done that show a lot of, I suspect there's a lot more benefits to what you're doing than have been fully described.
Yeah. Ready?
Is the loss of compliance plastic if you end up adding an anticyclin? Have you seen that ever be reversed?
Great question. Early on, yes. So I had a 3-year-old that was having repetitive shunt malfunctions. Ventricles were slit. They would never die. He is fine with that patient. He was constantly here. I added an anticyclin device. A year and a half later, he came in with a shunt disconnection and a mild headache. He never had a mild headache before. It was always constant 24/7 headache, and the ventricles were huge. So we corrected them. The problem is for how long? Because these anticyclin devices are not lifelong. I don't know how long. You can see that over 5 years, we lost some of the effectiveness. That's why it's important to have something that eliminates it. However, a difficult patient that I had, most of the residents here know, when she started seeing me when she was 12, and she's now in her 20s. It took 5 years to get her swinging between ICP -20 and +80 to -5 to +5. 5 years to improve her clinical function. So yes, we can correct some of it, but there is a point of no return. If you catch them years later, it's unlikely you're going to improve their headaches. It's unlikely you're going to improve their compliance signal.